male, he has presented with right hemiplegia. He has right hemiplegia. The symptoms started almost 3 months ago. Symptoms started 3 months ago and has progressed over 3 months time. Started 3 months ago and the symptoms have progressed over the 3 months time to complete loss of control of the right upper limb. Complete loss of control over right upper limb. So now, can this be called as a case of stroke? Now let's try to decode the definition. The definition says you have focal or global disturbance of cerebral function. What does that mean? Focal means some part of the brain. Global means all of the brain. So some part of the brain or all of the brain has lost its function. Well, in this case, some part of the brain has certainly lost its function because right side of the body is not able to move. There are motor weakness present. That means the left cerebral hemisphere, the motor area is dysfunctional. It's not working. So this part of the definition gets satisfied. Here the patient has disturbance of cerebral function. Of course, not whole of the brain, but focal. Some part of the brain is not working. But still, this does not qualify to be called as stroke. To call it a stroke, number one, the symptoms should have progressed rapidly. And when I say rapidly, we are referring to symptoms evolving over minutes to hours. Minutes to hours, not in terms of days, weeks, or months. So in this case, the patient problem started 3 months ago and it has slowly progressed to a point where today he is not able to move the right upper limb at all. He started noticing weakness 3 months ago. Slowly it has progressed. So this does not qualify to be called as stroke. Okay. Let us say there is another patient who is also 50-year-old, who is also male. He also has right hemiplegia. He also has right hemiplegia. And the symptoms have started just 10 hours ago. So it has progressed rapidly. Over 10 hours, he has developed right hemiplegia. But when we did an imaging, okay, so when we did an MRI of the brain, this person's MRI brain showed there is a tumor. There is a tumor in left frontal lobe. Left frontal lobe shows a tumor. So in that case, this is not a case of stroke. Why? Because the definition says whatever symptoms that arise because of loss of function of the brain should last for 24 hours or till the patient dies with no apparent cause other than vascular origin. Means the reason for losing the function of some part or all of the brain is something to do with the blood vessel. A pathology of the blood vessel has resulted in loss of function. Then only you can call it as stroke. Here, tumor is responsible for loss of function of the motor area. So then it doesn't qualify to be called as stroke because it's not a pathology of blood vessel, right? Clear? So you're getting the point. When symptoms evolve rapidly because of loss of function of some part of the brain within minutes to hours, and the reason for this loss of function is a pathology of the blood vessel, and the symptoms last for 24 hours or till the patient death, it can be called as stroke. Now, what is the pathology of the blood vessel we are talking about? Either a blood vessel can get blocked either because of stenosis or a thrombus formation. In that case, we will call that as ischemic stroke. Or a blood vessel can rupture and bleed into the brain. And when bleeding occurs, whichever part we are bleeding into, that part loses the function. And bleeding because of the rupture of a blood vessel is of course a pathology of the blood vessel. So that also qualified to be called as stroke. And in that case, I will call it as hemorrhagic stroke. Okay, is that clear? When you have loss of some or all of the brain's function resulting in some clinical signs and symptoms which evolve rapidly within minutes to hours, and these signs and symptoms last for 24 hours or till the patient death, and the cause for these all problems is either ischemia or hemorrhage, then we call it as stroke. But this is a little old definition. There are slight modifications in the definition, because if the symptoms last for less than 24 hours. Traditionally, what do we call if the symptoms last for less than 24 hours and resolve spontaneously without any treatment? We used to call it as transient ischemic attack. Transient ischemic attack. But there's a slight modification. What is the modification? Even if symptoms improve within 24 hours, but on imaging, there is an evidence of infarction. Like patient developed some right hemiplegia. We got a CT or MRI done. Symptoms improved over next 6 hours. Of course, they did not last for 24 hours. But when we got a CT or MRI done, we can see an infarct. So if infarct is visible, even if symptoms resolve within 24 hours, it will be still called as stroke. You're getting the point? Just give me a second, guys. I'm not able to see your comments. Okay, so that's what the stroke stands for. So the definition of TIA goes like this: a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. This becomes an important point. And when I say transient, that means lasting for less than 24 hours, but without acute infarction. If imaging shows an infarction, even if symptoms have resolved, it will be called as a case of stroke. Okay, is this clear? Now we know what is stroke. Can I also say that if you had transient ischemic attack, you have high risk of stroke? Because actually what happens is, in case of ischemic stroke, most likely you have a blood vessel which is occluded, most commonly because of a thrombus. Let us say this is one blood vessel which is going to brain and it is now blocked by thrombus. That's why you're not able to deliver the sufficient blood to brain and you're experiencing ischemia of the brain. And as you start experiencing the ischemia, slowly the neurons will start dying. Let's try to understand the pathophysiology of stroke. What exactly happens when you develop stroke? Let us say one of the blood vessel going to a particular area of the brain is blocked. Let's get a little bit of neuroanatomy of the brain. Now let us say I am looking at somebody's brain. This is a lateral view and this is going to be your central sulcus. The central sulcus. And anterior to central sulcus, above the sylvian sulcus, you have frontal lobe. And in the frontal lobe, if you look at this area, just anterior to the central sulcus, you have the primary motor area. This is the one which is concerned with, we'll label it as Brodmann area number 4. And this is the one which is concerned with contralateral motor function. This is your motor area. Now what this area does actually, it initiates the motor command signals required for movement of opposite side of the body. If I have to move left side of the body, right motor area has to initiate the command signals. If I have to move the right side of the right half of the body, the left motor area has to initiate the command signal. Okay, so it is concerned with the motor movement. And just anterior to it, somewhere here, you have one more area. This area is called as Broca's area. The Broca's area is the motor speech area, right? This is Broca's area or motor speech area, which is concerned with motor speech output. Understanding speech is the function of Wernicke's area, which is sitting here. Here you have Wernicke's area in the temporal lobe, which helps you to understand, decode the speech. But when you have to produce speech, it is the Broca's area which is responsible for it. Now, both these areas are getting actually blood supply from your middle cerebral artery. So let us say here I have the middle cerebral artery which is running in the sylvian sulcus. This middle cerebral artery has two divisions, one inferior division which gives blood supply to Wernicke's area and a superior division. This superior division gives blood supply to part of the motor area and this Broca's area. So superior division is supplying the blood supply to motor area and Broca's area. Motor area's superomedial part, which actually represents the lower limb control, is supplied by anterior cerebral artery, while the lateral inferior part, which is concerned with movement of upper limb and face, that receives the blood supply from the superior division of middle cerebral artery, and so is the Broca's area. Now, if I create a occlusion of this superior division of middle cerebral artery, the blood flow to Broca's area and the upper limb and face regulating part of the motor area is cut off. Okay. Now, what are the consequences that it will lead to? Once I cut off the blood flow, to some part of the brain. Remember here, the clot that got formed did not appear from nowhere all of a sudden. If it is getting formed there, it is slowly becoming bigger, right? So it might start with a small clot, and as time progresses, it starts becoming bigger. So flow keeps dropping progressively. Okay. So as long as I am able to deliver the blood flow of 20 to 25 ml per minute per 100 gram of brain tissue, means every 100 gram of brain tissue, if I'm able to deliver 20 to 25 ml of blood per minute, it meets all the requirements, means how much oxygen is required, how much glucose and other nutrients are required for cells in the brain, that is basically neurons, to survive and to be able to do their job. That requirement is met. So as long as I am able to deliver this much of blood, even if there is a clot or narrowing, nothing goes wrong with the brain, right? You will have normal functioning brain which is perfectly alive. But once the flow drops below this, when the flow drops below 18 ml, but you're still maintaining it more than 10 ml. So if I'm maintaining more than 10 ml but less than 18 ml, or you can say less than 20 ml, because we've written 20 to 25 ml as the normal flow. So if this is the range in which the blood flow is occurring as the clot becomes bigger, with this flow, the neurons can still survive, because for survival, whatever ATPs they need to spend, that much they are able to generate from whatever blood supply we are giving. But they can't work, because for them to work, we need to provide them 20 to 25 ml per minute of flow. If I'm not giving that much of flow, then the neurons start becoming dysfunctional, but they are alive. Neurons will still remain alive, but they lose function, but they become dysfunctional. So this area of the brain which is not getting sufficient blood supply to be functionally active but still alive, we will call that area as penumbra. We will call that as penumbra, or you can say ischemic penumbra. But now if the flow drops to less than 10 ml per minute per 100 gram of brain tissue, the neurons can't survive. Forget about being functionally active. If I'm giving 20 to 25 ml, they will survive, they will do their job. If the flow drops to 10 to 20 ml range, they stop functioning, but they can be alive. But once the flow drops less than 10 ml, neurons die. In whichever part of the brain the flow has dropped to less than 10 ml and neurons are dead, we will call it as infarct. We will call it as infarct. So basically what happens is, as the blood clot starts expanding in size, let us say this much area was to be supplied by this blood vessel. As the clot starts expanding, you will have different regions developing different blood flow. Or let us say this outer part is getting more than 20 ml flow. So this will function normally, right? And then you will also have an area, this much part, where the flow is dropped to less than 20 ml but more than 10 ml. So now this area is alive but in functionally inactive, right? So this becomes penumbra, right? So this becomes penumbra, and in the center, let us say the flow is less than 10 ml, that area becomes infarct. This is going to be penumbra and this becomes infarct. So every time a blood vessel gets blocked, whatever area it was supplying, the core center of that area generally has the least flow, so it becomes infarcted, and the surrounding where the flow is relatively less but sufficient enough to keep the neurons alive becomes penumbra, and the outer area where the blood supply is well maintained, it remains normal. But as time progresses and the clot keeps expanding, the flow here also starts dropping, so that also starts becoming infarct. So over time the penumbra starts getting converted to infarct. So to start with, the infarct may be small, but as the time progresses, the infarct starts expanding and the penumbra starts becoming smaller and smaller. Why am I stressing on this? It means time is extremely crucial factor in patients with stroke, because you catch hold of them early when the clot has just started. This entire area may be penumbra. The blood flow may be just between 10 to 20 ml. But if I catch hold of them later, then the penumbra shrinks, infarct expands, right? So it starts as infarct in the center, penumbra in the periphery. So to start with, you will have a small infarct, but as time progresses, infarct keeps expanding and the penumbra starts becoming smaller and smaller. So time is an extremely important factor. But why time is an extremely important factor? Because if I start opening this blocked blood vessel, let us say I do something and I clear this blocked blood vessel. Now this blood vessel is fully patent. Will I be able to recover the infarcted part? No, the infarcted part is dead forever. We cannot recover it. Even if I re-establish the blood flow, this will not bounce back to function again. But this penumbra, which was getting survival level flow, the cells are still alive. So if I re-establish the blood flow, I can recover this penumbra. Penumbra can come back to function again, right? So when we treat, we can't resolve the infarct, but we can salvage or save the penumbra. Okay, you're getting the point? So the main aim of stroke treatment is to save that part of the brain which is still not dead. The dead part of the brain is gone forever. Okay. So the earlier I treat, more area will be still alive. So I will be able to save more part of the brain. The late I treat, larger area would be infarct, smaller penumbra or no penumbra. So treatment holds less value the more delay I do in initiating treatment. Now my question is, don't you think if a blood vessel is getting blocked, there should be some counter mechanisms in our own body which can try to counter this? Yes, when a blood vessel is getting blocked, we have our own counter mechanisms which try to protect the brain. Only when they fail, we end up with penumbra and infarction. So what are those counter mechanisms? Whenever I'm developing a clot here, three counter mechanisms get activated. So one of the counter mechanism that gets activated is the ischemic parts of the brain produces vasodilatory substances like nitric oxide, adenosine. So one defense mechanism is vasodilators. Vasodilators will try to dilate the blood vessel that is blocked. So by dilating the blood vessel, I can re-establish the blood flow, right? So vasodilators like nitric oxide and adenosine get released and they will help you to get more blood supply to the ischemic part of the brain. Okay, nitric oxide and adenosine. What else can help me counter this problem that I'm facing right now? Second is body has own thrombolytic mechanism, which is your tissue plasminogen activator. So once you form a thrombus here, you will have tissue plasminogen activator produced in larger quantities and that will convert plasminogen to plasmin. And the plasmin is a fibrin breaking substance. So it breaks down the fibrin in the clot and it can dissolve the clot. So you have a own fibrinolytic system which can break down this clot. Number three, you can increase the blood pressure, and increase blood pressure means whatever narrow aperture you have, through that you may be able to deliver more blood to the brain, right? So increase in blood pressure. These are three counter mechanisms that can help you re-establish the blood flow to brain. Now, if it works well, all these counter mechanisms come into play, and if it works well, then maybe you will re-establish the blood flow to brain before an infarct develops. As the blood flow drops in this range, when you have the penumbra, nothing is infarcted yet. If I re-establish the blood flow through these counter mechanisms, then all the symptoms will resolve. In that case, it becomes a case of TIA. So basically, having a TIA means you already have high risk of stroke. You developed the thrombotic occlusion of one of the blood vessels, but your counter mechanisms protected you this time. The counter mechanisms could probably clear and re-establish the blood flow to the brain, and that is how they protected you this time. But if your counter mechanisms fail to protect you, then eventually you will end up with infarct, right? That is how we end up with stroke. But can I now strongly say that if you had a case of TIA, that patient is already sitting at very high risk of stroke? Yes, of course, because without the stroke risk factors, why would I end up with TIA? TIA is just nothing but one tiny step before stroke occurs. Just that this time you were lucky, your counter mechanisms have protected you. Next time, if they fail, you end up with stroke. So having TIA means you have very high risk of stroke. Okay, so I'm literally not able to keep track of your comments because there are so many. I will address if there are any important queries coming up. So what I emphasized is that whenever you develop occlusion of a blood vessel, it can lead to ischemic penumbra formation. Eventually, core starts becoming infarcted. But your counter mechanisms, if they are efficient enough in clearing the blocked blood vessel, then you can re-establish the blood flow before an infarct has occurred, and then all your symptoms resolve. Such cases will be called as TIA, and having a TIA means there is increased risk of stroke already. Increased risk of stroke. Most patients with TIA, they end up with stroke within next 24 to 48 hours. If not, almost 15 to 20% of patients who had TIA will end up with a stroke within next 3 months. Okay, so can I quantify the risk of stroke if I had a TIA? Yes, we have a scoring tool called as ABCD2 score, which can help you to quantify the risk of frank stroke occurring in a patient who already had TIA. And we don't have to put extra effort to understand this score, because in itself it is a mnemonic, where A stands for age more than or equal to 60 years. B stands for blood pressure, systolic BP more than or equal to 140 or diastolic BP more than or equal to 90 millimeters of mercury. C stands for clinical features of TIA, whether you had unilateral weakness with or without speech impairment. Means basically where weakness means motor symptoms. So if you had motor symptoms, we are giving 2 points. And if you did not have motor symptoms, you only had speech impairment without unilateral weakness, we are giving 1 point. If you had motor weakness, 2 points. Only speech impairment, 1 point. There are two D's. One D stands for duration, the other for diabetes. So if the TIA lasted for 60 minutes or higher, we give 2 points. And if it lasted 10 to 59 minutes, we give 1 point. Why this discrepancy? Well, basically it talks about your counter mechanisms efficiency. If there was a blocked blood vessel, and if your counter mechanisms like vasodilatory mediators and your own fibrinolytic system and rise in blood pressure, if they are able to re-establish the blood pressure more earlier, the TIA lasts shorter. If they take longer time to re-establish the blood flow, TIA lasts longer, right? So it tells about how efficient counter mechanisms are existing in you. So if they are not efficient, then the chance of ending up with a frank stroke is high. If they're efficient, the chance of ending up with a stroke is less. That's why longer the duration of TIA, more points given to it. And then diabetes, we know, is a strong risk factor for stroke. Stroke is considered as a macrovascular complication of diabetes. So diabetes is present, the chance of stroke occurring in the near future is high. So we give 1 point to it. Collectively, the maximum possible score is 7. The minimum possible is 0. We will assess the score for each patient who had an episode of TIA. And if the score is 0 to 3, the risk of developing the stroke is low. The risk of developing the stroke is low. And if it is 4 to 5, the risk of developing stroke is moderate. And if it is 6 to 7, the risk of developing stroke is very high. 6 to 7, the risk of developing stroke is very high. If you look at the 90 days risk of stroke, the patients who had a score of 6 or 7, at least 1 in 5, close to 1 in 5, or you can say 15 to 20% of the patients will develop a frank stroke within next 3 months or 90 days. Okay, so that's why every time you have a patient with stroke, you have to assess their risk of stroke, and accordingly we need to take some steps for minimizing the risk of stroke in the near future. Okay, so I hope now we have some basic clarity. What is stroke? When some part of the brain or all of the brain loses its function rapidly, means within minutes to hours, because of either a blood vessel getting blocked, that is ischemic stroke, or a blood vessel getting ruptured and resulting in bleeding in the brain, that is hemorrhagic stroke. If the symptoms resolve within 24 hours without an evidence of infarction, then we call it as TIA. But having TIA doesn't mean that you are totally out of problem. You are at very high risk of stroke. This time you were lucky that you did not end up with stroke. Next time you might end up with stroke, and we can assess how much is the risk of getting stroke by looking at this ABCD2 score. Clear? Okay. So now having understood what is TIA and what is stroke, let's go back to the stroke pathophysiology that we were talking about. We'll understand the classification of stroke and then I will take you through the stroke pathophysiology. So if you have a patient with stroke, a pathology of the blood vessel resulting in loss of function of some part or all of the brain, we call it as stroke. Stroke will be broadly classified into two groups. One is ischemic stroke, where a blood vessel is blocked. And remember, ischemic stroke is the most common type of stroke. This category accounts for more than 85% of all cases of stroke, while hemorrhagic stroke is relatively less common. Hemorrhagic stroke is relatively less common. This accounts for generally less than 15% of cases of stroke. Now, this ischemic stroke is further divided into thrombotic stroke, or thromboembolic stroke. Okay. Now, what do you mean by thrombotic stroke? There is development of a clot in situ, means inside the brain's blood vessel, a clot develops. Then it becomes thrombotic stroke. But if a clot gets formed elsewhere and then travels to the brain and blocks one of the blood vessels in the brain, then it becomes thromboembolic stroke. Right? Like if this is an artery and a clot gets formed here itself because maybe atherosclerosis, the rupture of atheromatous plaque, causing the endothelial injury, inviting the platelet plug formation and then fibrin deposition, then it becomes thrombotic stroke. But a clot formed elsewhere travels and then gets lodged in one of the blood vessels in the brain, it becomes thromboembolic stroke. We will talk a little bit about thromboembolic stroke, but before that, let's understand what are the risk factors for thrombotic stroke. The most important risk factor is going to be hypertension. The most common and a very strong risk factor is hypertension. Why hypertension is a risk factor? Because hypertension increases the risk of endothelial injury. Okay. Apart from that, diabetes, we just spoke about it. We had a score assigned for it in the ABCD2 score because diabetes causes vasculopathy or vascular injury. So that's a risk factor. Then dyslipidemia, because if you have a very high LDL-C, there is increased deposition of atheromatous plaques in the blood vessel that increases the risk of injury, endothelial injury. Then age. Most cases of stroke occur after 60 years. That doesn't mean strokes do not occur before 60 years. We have a separate category of patients which can be classified as stroke in young, but otherwise majority of the cases of stroke that we see are generally elderly. So age is an important risk factor. So is gender, because more stroke cases occur in males than females. Okay. Apart from these, smoking is a risk factor. Then increased homocysteine levels or hyperhomocystinemia is a risk factor. So these are all important risk factors for thrombotic stroke. Now talking about thromboembolic stroke, where a clot gets formed elsewhere and then travels to the brain's blood vessel, we can further classify them into two groups: artery to artery thromboembolism, and cardioembolic strokes. Artery to artery embolism, a typical example I can quote is you can develop a clot in the internal carotid artery or a main carotid artery, and from there the clot can go to the middle cerebral artery or anterior cerebral artery. That is an artery to artery embolism. Example: internal carotid artery to middle cerebral artery embolism. Cardioembolic strokes, typically you develop a clot inside the chambers of the heart, most commonly left atrium. From there the clot can go to left ventricle to aorta to carotid artery to middle cerebral artery, right? So risk factors for this: any condition where the left atria does not contract well, like in case of atrial fibrillation, The blood in the atrial appendage, where the movement is as such minimal, tends to form a clot. Why? Because Virchow had said, Virchow's triad, you remember, right? Endothelial injury, then stasis and hypercoagulability increase the risk of developing thrombus. And when atria is not contracting in atrial fibrillation, in atrial appendage, the blood is become static, doesn't move, so forms a clot. And from there, the clot can embolize. So important risk factor for cardioembolic stroke is going to be atrial fibrillation. Atrial fibrillation. Okay. Now talking about the hemorrhagic stroke. Hemorrhagic stroke are mainly two types. One, you can have bleeding in the brain's tissue, intraparenchymal hematoma or intracerebral hematoma. I'm not talking about intracranial. Of course, intracerebral is intracranial, but specifically bleeding in the brain tissue, intracerebral hemorrhage. And non-traumatic subarachnoid hemorrhage. Non-traumatic subarachnoid hemorrhage. These are hemorrhagic stroke. So that also means the subdural hematoma is not included here. So is epidural hematoma. These are not included here. SDH and EDH are not strokes. Why? Can anybody tell me why they are not strokes? Good morning, Jessica. Good morning, MedLife with Sahil. Okay. The fourth batch, fourth MBBS, yeah, I will update you soon. Okay, why these are stroke and why subdural and epidural are not stroke? Like if I have the brain here, okay, this is the brain. If I bleed inside the brain's tissue, it is intracerebral hemorrhage, right? Then if I bleed in the subarachnoid space, if it is non-traumatic, that is also hemorrhagic stroke. But if I bleed in this epidural space, a subdural space or epidural space, they are not considered as strokes. Why? Because when we look at the definition of stroke, what the definition of stroke has said, for losing some part of brain's function, the reason should be vascular in origin. So subdural hematoma and epidural hematoma, they don't have a pathology of the blood vessel. They are because of trauma most often, right? While intraparenchymal bleeding in the brain tissue often occurs because of high blood pressure, right? Hypertensive crisis. So hypertension is a disease of blood vessel. So that satisfies the criteria. And non-traumatic subarachnoid hemorrhage usually occurs because of rupture of berry aneurysms or AV malformations. So aneurysms or malformations of AV malformations are nothing but pathologies of blood vessel. So they also qualify to be called as strokes. But being traumatic in origin, the SDH and EDH do not qualify to be called as strokes. Clear? They do not qualify to be called as strokes. Okay, so I hope this part is clear. These are not strokes. The most common cause for intracerebral hemorrhage is going to be hypertension. And the most common non-traumatic. Remember, trauma can also cause subarachnoid hemorrhage. In that case, we will not call it as stroke. The most common cause for non-traumatic SH is rupture of berry aneurysms. So aneurysms are disease of blood vessel, and that's why we can call it as stroke. So far it's clear. If someone presents with rapid loss of neurological functions, it could be a case of stroke. And in that case, high chances that it is likely to be an ischemic stroke because more than 85% cases are ischemic and less than 15% cases are hemorrhagic in nature. Okay. Now in medicine, we will focus more on ischemic stroke. Why? Because if there is a bleeding inside the cranium, whether it is inside the brain or subarachnoid space or SDH, EDH, it falls in the territory of neurosurgeon. Neurosurgeon is supposed to manage it. All the crucial decisions are taken by them. So I will leave it to Dr. Sandeep, the surgery friend, to address the intracranial bleed, but we will focus more on the ischemic stroke in medicine. Okay. Now, so far what we have learned what is stroke. We have learned about classification of stroke. We have learned what is TIA. We will revisit the stroke pathophysiology that we were earlier talking about. Now let us say I have blocked one of the blood vessel, which is in this case the superior division of middle cerebral artery, and because of that, let's say the blood flow to different parts of the brain is affected differently, right? Let us say this part of the brain, the rest of the frontal lobe, the flow is 20 ml per minute per 100 gram of brain tissue. So this will be functionally normal, right? It will be doing all its job. But this part of the motor area, let us say the flow here is less than 10 ml. Then what will happen? With less than 10 ml, this part cannot survive. So this will become infarct. And let us say the Broca's area that we were talking about, here the flow is 15 ml. So if it is 15 ml, this part can't function. For it to be functionally active, it needs to have 20 ml per minute per 100 gram or higher. I'm not able to give it. So it loses the function. But it is still alive, because for survival, as long as I'm getting more than 10, I can be alive. So Broca's area has lost function, but it is alive. The motor area has lost function and it is dead. Rest of the brain is normal. It is functional and it is alive. Now, when this patient presents to me, what is going to be his clinical status? This is infarct. This is penumbra, right? The Broca's area has become penumbra. So both penumbra and infarct are functionally inactive, but infarct is dead. So in terms of clinical features or clinical symptoms, I will see the symptoms arising out of penumbra, which is not functioning, plus the symptoms arising out of infarct, which is also dead and non-functional. So what will be the clinical status of this patient? Broca's area is not working, motor area is not working. So he will have contralateral hemiplegia and Broca's aphasia. So when he presents to me, he will have contralateral hemiplegia because of the motor area infarct, plus he will have Broca's aphasia because of the penumbra involving Broca's area. Broca's aphasia. Now when I start doing something to open this blocked blood vessel and re-establish the blood flow, can I recover the infarct? No. This hemiplegia was because of infarct. So infarct cannot be recovered. So he will continue to be hemiplegic even if I open the blocked blood vessel. But when I open the blocked blood vessel, the penumbra will recover and the Broca's area's function can be recovered, right? So when he comes to me in the emergency room, he will be hemiplegic and can't speak. That's his status. When I treat and open his blocked blood vessel, he will still remain hemiplegic, but he will be able to speak. So can I say that my main focus of ischemic stroke treatment is going to be focused on recovering the penumbra, right? That is going to be the goal of my treatment when it comes to ischemic stroke. Now let's put in some facts and figures. Because as this blood vessel starts getting blocked, the flow is not going to get uniformly decrease in all the areas. We know that the flow will be least in the core of that area, and in the periphery it will be little better. So periphery tends to be a penumbra, core will become infarct. And as the time progresses, the flow in the periphery also starts dropping. So infarct starts becoming bigger and penumbra starts becoming smaller. Now after 24 hours, by no means you will have no area which is alive. Like all the area will become converted to the infarct. So let us say when the blood vessel got blocked, this is the territory supplied by a particular blood vessel. On Okay, guys, you're getting the voice now. So just give me a thumbs up if you're getting the voice. You're getting the voice. Just give me a thumbs up if you're able to hear me. Okay, I guess you're getting the voice now. I think my mic was battery down. Let me know from where you did not hear so that I can quickly revisit the key points, because there are a lot of concepts to learn here. And once that is sorted, we will get going again. Okay, so I was talking about. So could you hear the classification of stroke? So let me know if the classification of stroke was audible, so I can go further. Or if this was not audible, then I will revisit this. Because I can't see the timeline when the voice went off. Jayashri or Anand. Okay, so classification was clear, I presume. So in that case, this pathophysiology of ischemic stroke was clear. So classification was not clear. Okay, so let me quickly restart what we were talking about. I'll begin with the basics first again. So what is stroke? We have understood. Stroke basically refers to loss of function of some part or all of the brain which has evolved very rapidly within minutes to hours. And the reason for this loss of function is some pathology of the blood vessel. Either it was blocked, in that case it is ischemic stroke, or it has ruptured and blood, in that case it is hemorrhagic stroke. By traditional definition, the symptoms of this loss of function should last for 24 hours. If they improve within 24 hours, we used to call it as TIA. A small modification is, even if symptoms improve within 24 hours, if the imaging shows that there is a visible infarction, it will be still considered as stroke. If infarction present, then it will be called as stroke, even if the symptoms have improved. Generally, having a TIA means you are having high risk of stroke. And we can assess the risk of stroke using the ABCD2 score, where A stands for age, B for BP, C for clinical features, whether motor weakness or speech impairment. There are two Ds, one for duration of TIA and the other one is diabetes. The maximum score we can get is 7. So if you have a score of 4, 5, 6 or 7, you have moderate to high risk of developing a stroke in the near future. If a stroke is likely to occur in a patient with TIA, most often it occurs within first 24 to 48 hours, and remaining strokes can occur up to 90 days. So you have very high risk of stroke for next 90 days. Now, what actually protected these patients from developing a frank infarct during this TIA episode is basically the counter mechanisms. Counter mechanisms like vasodilatation, fibrinolytic system activation, and increase in the blood pressure. So one of you were asking, can collaterals act as counter mechanisms? Well, when you have an acute infarct developing, right, acute blockage of the blood vessel developing, you don't have sufficient time to build collaterals. When you have slowly evolving narrowing of the blood vessel like stenosis, their collaterals can evolve. But in case of the thrombotic occlusions, collaterals are not part of your counter mechanisms. Okay. Now, what else I taught you was, we learned about the classification of stroke. We classify the stroke into ischemic and hemorrhagic. 85% cases are ischemic stroke, where the blood vessel is blocked by a thrombus, where the thrombus may be formed in situ, inside the blood vessel itself. In that case, we call it as thrombotic stroke. Or the clot may be formed elsewhere and then come and get lodged in the blood vessels of the brain. In that case, we'll call it as thromboembolic stroke. Now, the thrombotic stroke commonly occurs in hypertensives, diabetic, people with dyslipidemia, smoking history, high homocysteine levels, elderly, or males more common than females. Thromboembolic stroke occurs either there is artery to artery embolism, where one of the artery develops a clot and from there it goes to the another artery in the brain, or cardioembolic, where the clot gets formed in the heart and then travels to brain. So if it is forming in the heart first, atrial fibrillation is a very strong risk factor. When it comes to hemorrhagic stroke, we have two categories here: non-traumatic subarachnoid hemorrhage and intracerebral hemorrhage. Intracerebral hemorrhage, where your blood inside the brain's tissue, most often occurs because of hypertension. Hypertension is a disease of the blood vessel, and in the definition of stroke, we have learned that the cause for losing the functions of the brain should be vascular in origin. Hypertension being a vascular cause, yes, it can be called as stroke. The most common cause for non-traumatic SAH is the rupture of berry aneurysms. Aneurysms are the disease of the blood vessel, so if they lead to bleeding, we can call it as stroke. But subdural and epidural hematomas are not strokes because they are traumatic in nature. They are not the diseases of the blood vessel. That's why it is not counted as stroke. Okay. Now in medicine, I told you I will focus more on the ischemic stroke because hemorrhagic stroke falls in the territory of neurosurgeons, because management is primarily surgical if at all needed. So I will leave it to Dr. Sandeep to address the intracranial bleed management. We will focus on ischemic stroke. So to understand ischemic stroke better, we again revisit the pathophysiology of stroke. So what happens is whenever a blood vessel gets blocked, the blood flow slowly starts dropping. As long as you're maintaining the blood flow to an area in the range of 20 to 25 ml per minute per 100 gram, that will live and be functionally active. So that's normal. But if the flow drops in the range of 10 to 20 ml, then that area can be alive but can't function. So that area becomes penumbra. And if the flow is less than 10 ml, that can't be alive. The neurons die and that area becomes infarct. So basically what happens is when a blood vessel gets blocked, at the 0 hour, the flow drops to less than 20 ml, but not less than 10 ml. So that whole area will be a penumbra. At the 0 hour, once the blood vessel is blocked, the entire area that was supplied by that particular blood vessel becomes penumbra. But as time progresses, the clot keeps becoming bigger, so flow keeps dropping. So as the flow keeps dropping, center of the area of that particular blood vessel's territory, flow may drop to less than 10 ml, so that becomes infarct. And as time progresses further, the clot keeps expanding, right? As the clot keeps expanding, the flow keeps dropping. So now initially everything was penumbra. After some time, infarct started appearing in the center. Periphery, we had the penumbra. So core was infarct, periphery was penumbra. As the time progresses and the clot keeps expanding, the flow keeps dropping, the infarct starts expanding in size. The penumbra, which was viable or alive tissue, starts shrinking. So after some time, you will notice infarct is bigger, penumbra is smaller. By the time you have completed 24 hours, you have no hope of finding any penumbra. Everything would be converted to an infarct. Okay, this is what I was talking about. Everything will be converted to an infarct by 24 hours. So after 10 to 24 hours, nothing will be left as penumbra. Everything will be infarct. And from studies, we know that within 4.5 hours, you will almost always have a reasonable sized penumbra present, the tissue which can be saved. So if we are talking about less than 4.5 hours, you will always have some amount of penumbra present. More than 24 hours, everything is infarct. Between 4 to 24 hours, you may have penumbra or you may not have, depending on how rapidly the blood vessel was getting blocked. You will have progression from little infarct and large penumbra to everything becoming infarct. So 4.5 to 24 hours, you may have some penumbra or may not have penumbra. But why Santhosh Sir is focusing so much on penumbra? The reason is, I gave you this example. I don't know if you heard or not. Let us say this particular person has got a block in the superior division of middle cerebral artery, which is supplying the blood to the motor area of the brain and the Broca's area. And once I started blocking it, let us say blood flow to the motor area dropped to less than 10 ml, then it will become infarct. But blood flow to the Broca's area is 15 ml. So at 15 ml, it can be alive, but can't function. So this becomes penumbra. So when I see this patient, at this stage, he has an infarct in the motor area and the Broca's area is penumbra. Okay. So when I see him, technically both the areas are dysfunctional. This is dead, it can't work. This can't work because it is not getting sufficient blood supply to work, but this is alive. So his clinical features are a combination of penumbra plus infarct. And when I open this blocked blood vessel and re-establish the blood flow, infarct cannot be recovered. It is dead forever. So I cannot expect the improvement in the motor function. But Broca's area, which is penumbra, if I re-establish the blood flow, the neurons are alive, they will start becoming functional again. So I can recover the Broca's area, but I can't recover the motor area. So if he has come to me with contralateral hemiplegia and Broca's aphasia because of motor area and Broca's area involvement, after treating motor area being infarct, it will not show any improvement. So he will remain hemiplegic. But he was also not able to produce speech. There were impairment in motor speech output, but that he will recover because Broca's area was penumbra. So he will recover that penumbra. So he will come with hemiplegia and impaired speech. He will go home after treatment with only hemiplegia without impaired speech. The speech part is recovered because that was penumbra. So when we talk about management of ischemic stroke, our whole focus is on salvaging or recovering the penumbra. Infarct cannot be recovered. It is gone forever. Okay. And in that case, what's my window of opportunity? If they present after 24 hours, there will be no penumbra. So nothing can be recovered. His disabilities will remain same. If he came to me with hemiplegia and Broca's aphasia, and if both the areas are infarcted, he will go home with the same state. I will not see any functional improvement. The disability will remain same. So if at all I can do something, it should be done within 24 hours. If I can detect the patient before 4.5 hours, it's beautiful because I will have a sizable chunk as penumbra and maybe very small part as the infarct. So that's the best window of opportunity for treatment, right? So can I make a statement and say time is brain? Because after the onset of stroke, the more late they present, more brain tissue is lost to infarct and you will have smaller penumbra available. And after 24 hours, anyway, no penumbra available. So time is very, very crucial, right? So let me write this statement. Time is brain. You will hear these words in the corridors of emergency room very often. Time is brain. The more time lost before I initiate treatment, more brain is lost. Okay. So can I say the goals of treatment of ischemic stroke are basically to save the penumbra. Goals of treatment of ischemic stroke is to save penumbra. Now, how saving penumbra makes a difference to patient's life? Because it reduces the disability, right? So goals of treatment is to salvage penumbra. By saving the penumbra, we can reduce the disability. By saving the penumbra, we reduce disability. Because if I don't save the penumbra, that will also become infarcted and he will remain disabled, right? And can I say by reducing the disability, I reduce the risk of death in patients with stroke? The second goal of stroke treatment is to decrease mortality, decrease risk of death. And the third goal, okay, so this time you treated it efficiently, you saved the penumbra, you minimized the disability, you took necessary steps to prevent the death in this person. But then he is diabetic, he is hypertensive, he has dyslipidemia, he has hyperhomocystinemia, he is male. So he is sitting at a very high risk of stroke. So another episode of stroke can still occur in him. This time he was lucky because he found the right hospital, right doctor like you, so you helped him. But next time you never know. So I have to prevent future episodes of stroke. We also need to prevent further stroke. So these are going to be my goals of treatment. I have to prevent further stroke. Okay. Now why patients of stroke die? What are the common causes for mortality in stroke? Because Santhosh Sir is making a statement that it's your job to minimize the risk of death, right? So mortality in stroke. There are two major reasons for death in stroke. The first one is aspiration pneumonia. Aspiration pneumonia. The second one is disability. Now, can disability kill someone? The third one is cerebral edema, but that is not a very common complication in case of ischemic stroke. In case of hemorrhagic stroke, it very often occurs. You'll have raised intracranial tension, brainstem herniation, and death, but it's a less common occurrence in case of ischemic stroke. So we'll concentrate on the common ones: aspiration pneumonia and disability. Okay, now how aspiration pneumonia occurs in a patient with stroke? Normally, we produce anywhere between 1.5 to 2.5 liters of saliva and other oropharyngeal secretions. 1.5 to okay, 1.5 to 2.5 liters of oropharyngeal secretions that include saliva and other secretions. Now, what is the fate of those secretions? 1.5 to 2.5 liters per day is a huge amount. So what we do? Most often we swallow it. So right now when I'm talking to you, I'm producing saliva, and intermittently in between, if you have noticed, I'm swallowing it. You're also swallowing it. The other possible fate of this secretion is spit it out. And for some unknown reason, Indians have a tendency to spit a lot in comparison to rest of the world. We can see the evidence of this on the walls, corners, everywhere. But one thing is clear, we can either swallow or spit it out. But if you become drowsy because of stroke, then you lose your ability to spit out, and you might also lose your ability to swallow. So in that case, these oropharyngeal secretions can trickle into the trachea, go into the lungs, and when it trickles into the lungs, it is carrying the bacteria from your oropharynx. A lot of anaerobes that are there in the oropharynx, there may be commensals in the oropharynx, but when they are introduced to the sterile lung environment, they can become infective and they can cause aspiration pneumonia, very often caused by anaerobic organisms. Okay, so that's why preventing this is important, because aspiration pneumonia, if the stroke doesn't kill you, aspiration pneumonia can kill you. Second is disability. Now imagine I have a very major stroke. I've become densely hemiplegic. I have global aphasia. I don't understand speech. I can't communicate. So I'm extremely disabled. In such cases, mostly I'm going to be confined to bed. I will become bedridden. And once I'm bedridden, a chain of negative events start. Because once I become bedridden, I become prone for developing deep vein thrombosis, because mobility is less. I can develop a DVT. It can embolize to my lungs, what you call as pulmonary embolism. I can die because of that. If I'm staying prolonged periods in the bed, I can develop pressure sores, mainly in the gluteal region, very close to anal aperture, can get contaminated, can develop bad infection, sepsis, and I can die. If I'm having prolonged immobilization, my muscles can get atrophied, my bones become osteoporotic, so I become more prone for falls or frailty, and one fall, I can develop a hip fracture, and a hip fracture means the death bugle, because you become more confined to bed and the other complications related to confinement increase. So disability does contribute to mortality. So today, by saving the penumbra, by minimizing the disability, I can indirectly reduce the mortality, right? So to reduce mortality, we need to minimize disability. To minimize disability, I need to save the penumbra. Okay. Now, whatever I can do to save the penumbra, we will call that treatment as revascularization. We will call it as revascularization. You have one blood vessel which is blocked. You open that blood vessel through whatever techniques you have right now. So we'll call it as revascularization. Okay. And whatever I do to prevent future episodes of stroke, we will call that as secondary prevention, because already an episode of stroke has occurred. We are trying to prevent future episodes of stroke. So if I try to prevent the first episode of stroke, then it becomes primary prevention. Already one episode has occurred, we are preventing further episodes, then it becomes secondary prevention, right? So in terms of management, I have two major things to accomplish. Think about revascularization and secondary prevention. Now, what methods are available for revascularization? Because when we spoke about MI, revascularization in MI can be achieved, especially STEMI can be achieved by either angioplasty or thrombolysis, right? Angioplasty or thrombolysis. Now here, what options I have? The pathophysiology wise, it is same, right? You have a blocked blood vessel with a thrombus, so you can dissolve with thrombolytic agents. So you can think of thrombolysis, which is one choice. And something similar to angioplasty can be done here as well. You can go into the blood vessel with a guide wire and retrieve the clot. Only thing is, we don't call it as angioplasty, PCI or PTCI here. We call it as endovascular thrombectomy, or the previous term is called as mechanical thrombectomy. So you can either call it as endovascular thrombectomy or mechanical thrombectomy, EVT. endovascular thrombectomy. You're putting a guide wire and trying to reach the blood vessel of the brain. You call it as EVT, endovascular thrombectomy. And this thrombolysis is also called as IV thrombolysis because you're giving the thrombolytic agent IV, so you can call it as IVT. IVT and endovascular thrombolysis. These are the two choices we have for re-establishing the blood flow to the brain. Okay. Now, what can I do for secondary prevention? For secondary prevention, one thing I can do is risk factor management. If you're hypertensive, I can try to keep your BP under control. So risk factor management is an important step when it comes to prevention of future episodes of the stroke. Number two, like for example, hypertension, I can keep the BP less than 130/80 so that future episodes of stroke don't occur. Diabetes, if I can keep the HbA1c less than 7, I can minimize the risk of future episodes of stroke, right? If I have hyperhomocystinemia, I can treat it. If there is dyslipidemia, I can keep the LDL-C under control. So yes, risk factor management is important. Further, in addition to that, we also think about antiplatelets so that even if an atheromatous plaque rupture occurs in the future, the platelet plug formation is minimized. And atheroma progression can also be reduced by keeping the cholesterol under check. So I can also think about adding statins. So these are the basic steps we can take to prevent future episodes of stroke. Now our focus should be more on revascularization because this is what is helping minimize the disability and keep the patient mobile and reduce the risk of death. Okay, so how do we strategize? Which one should I go for? Thrombolysis or endovascular thrombectomy? In case of STEMI, our clear-cut choice was PCI or angioplasty because it is always superior to thrombolysis. So we go for angioplasty only when angioplasty is not feasible because you don't have a cath lab equipped center where patient has reached. And even by referring, it is going to take a lot of time to get it done. Then we go for thrombolysis, right? But in case of stroke, the scene changes a bit. What is the change? I'm coming to that. We will address both the thrombolysis as well as EVT. How we make that choice? So there are certain eligibility criteria for thrombolysis, certain eligibility criteria for endovascular thrombectomy. So the issue here is, okay, I'll tell you my own experience. So when I was in a medical school and I asked one of the professors, sir, the pathophysiology of STEMI or like MI and the pathophysiology of stroke is pretty same. You have occluded blood vessels. And we can do thrombolysis for both the MI as well as stroke. But why angioplasty is only done for cases of MI and same thing is not done for stroke? So when I asked this question, I was kicked out of the class. He said, out. Because back then, 25 years ago, even thinking about doing something like angioplasty to the brain was a very utopian idea. Nobody would have probably even thought about it. So it's like, what crazy question is that? Get out of my class. But things have changed over time. The main issue was reaching the coronaries is pretty easy with a guide wire. You get into any of the artery, it will lead to aorta. From the aorta, getting into the coronaries, right or left coronary is pretty easy. But reaching the blood vessels in the brain was complex, difficult, because they have very tortuous course. So canalizing and getting into those tortuous blood vessels was very, very difficult. But with the advancement of time and technology, malleable guide wires are there, and now we are able to reach, if not all, some blood vessels in the brain. So endovascular thrombectomy, though theoretically being superior, is not possible for all the blood vessels in the brain, even with today's advancements. While thrombolysis can be considered regardless of where the clot is there in the brain, right? So that makes the things a bit complex. In case of STEMI, it was pretty easy. We can reach all the blood vessels. So if you have a STEMI and you have the facility for PCI, go ahead and do the angioplasty. Only when that was not feasible, we thought about thrombolysis. Here things get a bit messy because EVT is best but not feasible for all the stroke cases, while thrombolysis is feasible for all stroke cases, but it's a risky procedure. So let us see how we make the decision whether I should go for IVT, whether I should go for Okay, so let us say we got a case of stroke. We already know time is brain. So once you get someone with rapidly evolving neurodeficits, it's probably a case of stroke. The first thing I need to know is whether I am dealing with an ischemic stroke or a hemorrhagic stroke. So for that, the best investigation is non-contrast CT. Now let me tell you, you can't see an infarct in most cases of stroke within 6 hours of onset. If I'm doing the CT scan may not be able to pick up an infarct within 6 hours. MRI can detect sometimes as early as 30 or 40 minutes. So then why non-contrast CT becomes my investigation of choice, go to investigation and not MRI? Can anybody tell me why it is not the MRI is the not investigation of choice? Because if you do CT, infarct becomes evident after 6 hours if it is CT. But if you're doing MRI, it can detect before 6 hours. So why am I not going for MRI? Well, the first thing is, before asking for an investigation, we should always have a clear-cut question in my mind. Like, I'm searching for some answers, right? So I should have a question in my mind, and to get the answer for that question, I'm getting the investigation done. For example, if I'm asking urine culture, what's the question in my mind? Oh, this patient has UTI. That's already confirmed by urine routine examination. Now I want to know which organism. So I have a question in my mind. Which organism is responsible for this UTI? To get the answer for this question, I am getting the urine culture done, right? So similarly here, what is my question? I have a patient with stroke. This could be hemorrhagic or this could be ischemic. Clinically, it is stroke. Hemorrhagic or ischemic only imaging can tell me. So I need the answer for this question. Am I dealing with hemorrhagic stroke or am I dealing with ischemic stroke? I don't have any itch to see an infarct. Even if I don't see an infarct, if an investigation can solve my query, that's more than enough. CT is highly sensitive for detecting bleed. It doesn't miss the bleed easily. It will miss the infarct up to 6 hours. It may not show you, but you don't miss the bleed. So if I get a CT done, it shows bleed, then it is hemorrhagic stroke. If it does not show bleed, then it is ischemic stroke. As simple as that. Amir Ali, very good. Yes, that's exactly the point. We don't want to see the infarct. I just want the answer whether it is ischemic or hemorrhagic. So that's why CT does the job. In pediatric age group, we do consider MRI instead of CT, because in pediatric age group, strokes are less common and there are other stroke mimics which can look like stroke, rapidly evolving neurological dysfunction, but it is not stroke. So there, yes, we don't want to miss stroke mimicking as stroke, and that's why we go ahead with MRI. But in adults, if someone presents with two rapidly evolving neurodeficits, it's almost always stroke. That's why we just rely on CT. So if the non-contrast CT, when we're doing non-contrast CT, we often try to get the CT angio also done in the same sitting if it is feasible. If not feasible, okay, you just stick to non-contrast CT. There is a reason why we are doing CT angio. I'll tell you about that later. Once you get the non-contrast CT done, if you see bleed present there, if the bleed is present, then it becomes hemorrhagic stroke. Then it becomes hemorrhagic stroke. So I will refer it to a neurosurgeon and wash my hands. But if there is no bleed, then it is ischemic stroke. So now it is in my field. It is ischemic stroke. Now it is my field. Now I have to decide how do I manage this case, right? So let us see how we manage. So you got a non-contrast CT done with CT angio, and non-contrast CT said that this is a ischemic stroke because there is no bleed. If I saw an infarct, good. If I don't see an infarct, still it is ischemic stroke. Now the next question is, how am I going to manage a case of ischemic stroke? We have already learned what are our goals of treatment, right? If I have ischemic stroke, our goal of treatment is to save the penumbra. By saving the penumbra, disability comes down and indirectly mortality comes down, and for that revascularization is my solution. Revascularization can be done with thrombolysis or endovascular thrombectomy, and prevention of future episodes of stroke. So let's see how I can accomplish that. Once it is a case of ischemic stroke, how am I going to accomplish it? So once you have a case of ischemic stroke, you have to know whether it is a major stroke or minor stroke. Because if it is minor stroke, we don't need to treat it aggressively. I probably don't do anything major. But if it is major stroke, it needs aggressive management. But now how will I decide whether it is major stroke or minor stroke? There is a scoring system called as National Institute of Health Stroke Severity Scale, or NIHSS score. More the score, more severe the stroke is. Okay, you don't have to know the components of the score. If the score is more than 3, or if the score is less than 3, less than or equal to 3, anything more than 3 NIHSS score makes it major stroke. It becomes major stroke. And if it is less than or equal to 3, it becomes minor stroke. It becomes minor stroke. Basically, we are assessing how much disabled the patient is because of the stroke. The more disabled the patient is, it's a major stroke. If you are having major stroke, please remember, if you are seeing older editions of the textbooks, the score of more than or equal to 6 was major stroke, but in 2026 it is revised. Now score of more than 3 is major stroke. If it is a major stroke, you have to treat them with revascularization. If indicated or if feasible. So these patients should be treated with revascularization. If it is minor stroke, we are taking some further steps to know whether this is a minor stroke without disabling symptoms or with disabling symptoms. Without disabling symptoms or with disabling symptoms. Now, what do I mean by this? Let us say I have got a patient with stroke. He came to the emergency room, and when we looked at his story, it's like rapidly evolving neurodeficits. We got the NIHSS score done, and if it is pointing towards major stroke, certainly we are going ahead with endovascular thrombectomy or thrombolysis or whatever revascular strategy we can decide. But if it is minor stroke, the score was low. In that case, I will see what are the symptoms. Like, let us say I have one patient with score less than 3, and his symptoms are mainly aphasia. Aphasia will be considered as a disabling symptom, right? Like if I have Broca's aphasia or Wernicke's aphasia, it's a disabling symptom. If I have Wernicke's, I'm not able to understand speech. It is severely going to affect my quality of life. Or if I have Broca's aphasia, then I understand what you're saying, but I cannot respond back. So that is disabling symptom. On the other hand, I have another patient whose score is similarly low, but his symptom is mainly, let us say, slurring of speech. He does not have any motor weakness. If there was motor weakness, invariably it will become a major stroke as per the score. He doesn't have any hemiplegia, monoplegia or anything, no motor weakness. Only symptom he has is slurring of speech. So it's a minor stroke, and slurring of speech is not a disabling symptom. You're still able to understand, you're still able to communicate, but slight slurring. So that's the minor stroke without disabling symptoms. So if I have minor stroke with disabling symptoms, in the past, these cases were not taken up for revascularization. But today in 2026, these cases can also be taken up for revascularization. So their treatment is going to be again thinking about revascularization. So can I say 2 sets of patients go for revascularization? Those who have major strokes and those who have minor but disabling symptoms are present. And those who don't have disabling symptoms, we don't go for any revascularization therapy. They don't need. The benefit is less. So we don't go for revascularization therapy. all we offer for them is dual antiplatelet therapy for first 21 days. Dual antiplatelet therapy for 21 days. Followed by that, you go for single antiplatelet therapy lifelong. Single antiplatelet therapy lifelong. Okay, clear? So if you have a very minor stroke, no disabling symptoms, nothing aggressive doing, start them on aspirin plus either clopidogrel. Earlier we only used to use aspirin plus clopidogrel for first 21 days. After that, aspirin lifelong. Now from 2026 onwards, in place of clopidogrel, you can also use ticagrelor. So it's like aspirin plus clopidogrel or aspirin plus ticagrelor for first 3 weeks. After that, rest of the life, aspirin alone. This is for non-disabling minor stroke. Disabling minor stroke and major stroke, we are going for revascularization. Okay. Now the question is, what is going to be my revascularization strategy? The revascularization strategy can involve thrombolysis. Okay, let me use the technical term, that is thrombolysis is IVT or endovascular thrombectomy or both based on eligibility. Very, very important point. So based on the eligibility, patient will undergo one of them or both of them. So there are certain eligibility criteria for thrombolysis and EVT. If the patient meets eligibility criteria for only thrombolysis, he will undergo only thrombolysis. If he meets the eligibility criteria for EVT, only EVT, he will undergo only endovascular thrombectomy. But if he meets the eligibility for both IVT as well as EVT, then we do both. Unlike the management of MI, where if we are going for angioplasty, then we don't do thrombolysis, right? But it's not the case here in case of the brain stroke. Based on their eligibility, they will either undergo one of them or both of them. So that means we should know what are the eligibility for IVT and what are the eligibility criteria for EVT. Eligibility criteria for IV thrombolysis and endovascular thrombectomy. So IV thrombolysis, the eligibility criteria is, number one, I think I have already told you that if the patient has presented within 4.5 hours of onset of the stroke, we clearly know that you will find a sizable chunk of the brain tissue as penumbra, and it's certainly worth taking a risky step like administering thrombolytic agents to save that penumbra. Okay. So within 4.5 hours, they definitely become eligible for thrombolysis because you will have a penumbra. After 24 hours, they are certainly ineligible. Between 4.5 to 24 hours, you may have a penumbra. So you may consider, but the point to keep in mind here is thrombolysis is not a very safe procedure at all. Anywhere between 10 to 30% of the patients might bleed because of thrombolysis. So you're always weighing the risk and benefit. Thrombolysis is giving you risks, giving you benefits. Within 4.5 hours, because you have a large penumbra, certainly that risk is definitely inferior to the benefits that I'm going to get. After 24 hours, anyway, there's only risk, no benefit. But between 4.5 to 24 hours, as the infarct keeps expanding and the penumbra keeps shrinking, the risk versus benefit ratio is a bit difficult to gauge. So what we know so far is 4.5 to 9 hours, you may go for thrombolysis by assessing the risk versus benefit ratio. After 9 hours, the risk of bleeding is high than the benefit of saving the penumbra. So we don't go for thrombolysis after 9 hours. Though up to 24 hours, you might have a penumbra, the risk benefit analysis doesn't favor continuing beyond 9 hours. So that's why when we talk about IV thrombolysis, the acute ischemic stroke patients presenting within 4.5 hours are clear indications. Within 4.5 hours are clear indications. This is what we call as the standard window of opportunity for thrombolysis. Standard window for thrombolysis. But 4.5 hours to 9 hours, we can decide by analyzing the risk benefit. If you feel that benefit is more than the risk, then you can still go ahead with thrombolysis, and we will call this as extended window. This is new as per 2026 ASA stroke guidelines. This is a new window created. Earlier we used to talk about only up to 4.5 hours. Okay. Acute ischemic stroke presenting within 4.5 hours or 4.5 to 9 hours and not after that. And there should be no contraindications for IV thrombolysis. If there are contraindications for IV thrombolysis, by default the patient becomes ineligible for IVT. So what are the major contraindications in that case? The major contraindications for IV thrombolysis include, number one, if the BP is more than or equal to 185 by 110. Please note, I am writing here despite treatment. Means if the patient comes, let us say within 4.5 hours, he is in the window of opportunity for thrombolysis, but BP is, let us say, 200 by 120. It is higher than this, but if you still have time, you can take steps to quickly lower it, and if you are able to lower it below 185 by 110, you can still go ahead with thrombolysis. Only when despite treatment you are not able to bring it below 185 by 110, it becomes a contraindication for thrombolysis. Now, why is this a contraindication for thrombolysis? Because once you have a blood vessel which is blocked, your counter mechanisms have tried to somehow maintain the blood flow to the brain, and one of them is increase in the blood pressure, right? So increased blood pressure is one of the physiological adaptations which is trying to keep the brain alive. The penumbra that I'm seeing here is because of the increased blood pressure. Our blood vessels are designed to tolerate a blood pressure of 220 by 120 millimeters of mercury comfortably. So up to this much, my blood vessels can actually tolerate. So it's a good adaptation that body is trying to do to keep the penumbra alive. So right now what I'm seeing as a penumbra may be alive because body has increased the blood pressure and delivering the blood to that part of the brain. But if I'm going to dissolve this clot, the issue is I may be tolerating 220 by 120 when I have normal blood vessel, but under the thrombolytic drugs, my tolerance drops. I might bleed instead of, like earlier I would have bled if it is more than 220 by 120, but if I'm giving a thrombolytic agent, I can bleed when I'm having a BP of more than 185 by 110 itself. So that's why if you're administering thrombolytics, then the BP should be less than 185 by 110. Okay, so if I fail to achieve that, it becomes a contraindication. So that is one. Second, if there is recent major surgery, especially if patient has undergone some major abdominal or intracranial surgery, or a patient has some coagulopathy or severe thrombocytopenia, there is increased risk of bleeding, and giving a thrombolytic agent becomes risky. So these are going to be contraindications. So now tell me, what makes the patient eligible for IV thrombolysis? He should present within 9 hours, within 4.5 hours the standard window, 4.5 to 9 hours the extended window, and he should have no contraindications for IV thrombolysis, right? Then he becomes eligible for IV thrombolysis. Now the eligibility for the EVT. So for the EVT, the issue with the brain angioplasty, what we today call as EVT, was we were not able to reach all the blood vessels, right? So even today we can't reach all the blood vessels. So if you have an acute ischemic stroke patient presenting either within 6 hours or 6 to 24 hours, because up to 24 hours you have a hope of finding penumbra. After 24 hours, as we know, everything is going to be infarct. Within 6 hours, a very high chance that you might have a penumbra. So within 6 hours, for EVT, that's the standard window. This is the standard window for EVT. 6 to 24 hours is the extended window for EVT. I did not extend the window of thrombolysis to 24 hours despite knowing that I might have a penumbra. I kept it to less than 9 hours because after 9 hours, the risk of thrombolytic induced bleeding is high than the benefit of saving the penumbra. That's why the risk benefit analysis favors sticking to less than 9 hours. But EVT doesn't have major risk of inducing bleeding or anything. It's a relatively safe procedure. That's why up to 24 hours it can be done. Okay, acute ischemic stroke presenting within 6 hours or 6 to 24 hours in both the cases, with whether within 6 hours or within 6 to 24 hours with a large vessel occlusion, with a large vessel occlusion. This is a very, very important point. Means our current technology allows us to cannulate only the larger blood vessels. We cannot go to the deeper small blood vessels. So if there's a clot sitting in a small blood vessel in the brain, I can't do EVT for it. I can only do for large vessels. So now what all blood vessels we can actually do the clot retrieval from? The first one is intracranial part of the internal carotid artery. It's a large blood vessel proximal. I can easily go there and retrieve the clot, right? So internal carotid artery. So if I have a patient who has ischemic stroke, he has presented within 24 hours and the clot is sitting in an internal carotid artery, he is eligible. Okay. Or if the clot is sitting in the M1 segment of MCA, the middle cerebral artery has a, like, its course is divided into proximal M1 part, then M2, M3, M4, like that. So I can reach up to M1. Selected cases of M2 can be considered. The M2 MCA, but not all patients, only selected. As an undergraduate student, if you don't remember the M2 part, it's perfectly fine. But the M1, yes, those are standard candidates for EVT. Okay. This is about middle cerebral artery and internal carotid artery, anterior circulation primarily. The posterior circulation, now we can do for posterior circulation also. So that includes your basilar artery occlusion, then basilar artery occlusion, then vertebral artery occlusion, vertebral artery occlusion, and we can also do it for the P1 segment of posterior cerebral artery. So we are capable of doing EVT for all these locations. Clear? But let us say I have a patient who has presented within 6 hours of onset of stroke. But if the clot is sitting in, let us say, M3 segment of MCA or P2 segment of PCA, he becomes ineligible for EVT. Like, even if I want to do it, I can't reach there. So it's not feasible, right? So now what we do is, whenever we have made a diagnosis of ischemic stroke and it is either major stroke or it is a minor stroke with disabling symptoms, we need to go for revascularization. So I have to see whether he is eligible for IVT and or EVT, and whatever he is eligible, we will do all. If he is eligible for IVT plus EVT, we will do both. If he is eligible for only IVT, we'll only do IVT. If he is eligible for only EVT, we'll only do EVT. Okay. So let us put a flow chart of the approaches. So let us say I have developed a case of ischemic stroke and I have to now decide whether deciding about IVT, and then we will learn decision about EVT, right? So if I have an acute ischemic stroke, what really matters to me is the time since onset. Now, many cases what happens is time since onset is not known. It's like, let us say there is someone who was last seen normal at 4 p.m. and when the son goes to see the patient again at 7 p.m., he's having stroke. He's hemiplegic, aphagic. So then when did the stroke occur? It would have occurred anywhere between 4 when he was last seen normal and 7 when he was actually seen with stroke, right? So in such cases, what we do is, the last known well is taken as the time of onset of stroke if it is not a witness stroke. If it is witness stroke, it is pretty simple, right? The father was having food, son was also having food, and then son noticed that the food dropped from father's hand and then he became hemiplegic in front of his eyes. So then it's a witnessed stroke. The time of onset is well known. If it is not known, then we will take last known well as the time of onset of stroke. Okay. So if that last known well is less than 4.5 hours, less than 4.5 hours, by default he is eligible for by default he is eligible for thrombolysis, right? So we will go ahead with thrombolysis if there is no contraindication. If no contraindication. Okay. And if he has presented after 24 hours, we know certainly there is no hope of thrombolysis because everything will be infarct. Or if he has presented after 9 hours, though you might have a penumbra, it's not worth taking that risk. So in both these cases, after 9 hours or after 24 hours, they become ineligible for IVT. They are ineligible for IVT. So if they are between 4.5 to 9 hours, that is my extended window. Let's see what we do. If within 4.5 hours, we clearly know there will be a sizable chunk as penumbra and we will go ahead with thrombolysis. But if it is 4.5 to 9 hours, I want to see whether penumbra is there or not. If I have a penumbra, okay, it's worth taking the risk of giving the thrombolytic agents. And if I don't have the penumbra, then giving the thrombolytic agent is only bringing risk, no benefit, right? So I want to see whether penumbra is there or not. After 9 hours, even if penumbra is there, I don't want to take the risk. After 24 hours, anyway, penumbra will not be there. Everything will be infarct. So what investigation I can do to see whether penumbra is there or not between 4.5 to 9 hours? We will go ahead with CT or MR perfusion imaging, which helps us to identify the presence of penumbra. Perfusion imaging, which helps us to identify the presence of penumbra. Okay. And if penumbra is present, then certainly it is worth taking the risk. So you'll go ahead with thrombolysis. If there is no penumbra, then there's no point in giving the thrombolytic agents. It's unnecessarily risky, right? So then these patients become ineligible for IV thrombolysis. They may be still managed with EVT if they're eligible. Because as I've already told you, IVT, EVT, whatever they're eligible, we will do. If they're eligible for both, we will do both. Okay, clear? Okay, so I hope the decision about IVT is sorted. If you have an ischemic stroke, time since onset matters a lot. Less than 4.5 hours with closed eyes, you can go ahead with thrombolysis if no contraindication. 4.5 to 9 hours, you have to prove that there is a penumbra and that can be saved. So that's why you will go ahead with CT or MR perfusion imaging. After 9 hours, after 24 hours, nothing doing, thrombolysis is out of the window. Okay, now I have one question. What if it is a wake-up stroke? What if it is a wake-up stroke or clearly unknown onset? Means last well-known is also not within the reach. In the sense, it's like someone is staying alone and 2 days back somebody had seen him, and today, because he had not come out of the house, neighbor goes to check on him and then he notices that he was lying there in an hemiplegic state. So in that 2 days period, anytime the stroke would have occurred, right? If I'd seen him 3 hours or 4 hours back as normal, then fair enough. Last known well as becomes the probable time of onset. That's how we think. But if last known well was beyond 24 hours, then I don't know when it occurred. Did it occur 24 hours ago or 6 hours ago, 4 hours ago? So that is where decision making becomes a bit difficult. Or the wake up stroke, like the person goes to sleep, he was fine, then he wakes up in the morning, which may be like 8-9 hours later, and when he wakes up, he's waking up with a stroke. So it could have, if I follow that concept of last known well, and if he has woken up after 9 hours, then already 9 hours window is out. But there's a possibility that stroke might have occurred in the middle of the night or early in the morning. So I miss opportunity of treating some salvageable penumbra cases. So what we do is, if it is a wake up stroke or clearly the onset is not well known, in such cases, you can still consider thrombolysis or IVT if they meet any of these following criteria. Number one, if there is a diffusion weighted imaging flare mismatch. Now, what do I mean by this? You can go for an MRI in such cases. You can go for an additional MRI where you will get a diffusion weighted imaging and a flare sequence. So if there is an infarct, MRI picks up quite early, right? So on the diffusion weighted image might show an infarct. But on the flare sequence, if I don't get corresponding signal changes, because flare changes appear late. If there are no signal changes, means the place where I'm seeing infarct, I should be seeing some flare signal changes. But if I'm not getting that, we will call this phenomenon or outcome as the diffusion weighted imaging flare mismatch. We'll call it as mismatch. Because after the infarct becomes evident here, the flare changes appear little late. So if you're seeing that mismatch, it means the infarct is less than 4.5 hours in duration. After 4.5 hours, you will start seeing the signal changes on the flare sequencing as well. So this mismatch can help us to identify infarcts less than 4.5 hours duration. Right? It is suggestive of stroke of less than 4.5 hours duration. So of course, in that case, it's now sorted, right? It is less than 4.5 hours in duration, so I can definitely go ahead with thrombolysis. Second is, this is what I would prefer to do instead of trying to do the diffusion weighted imaging and flare mismatch. I would rather go ahead with a CT or MR perfusion imaging, because this is the best tool. If there is a penumbra present, you can certainly go ahead with thrombolysis. If there is a penumbra present, you can certainly go ahead with thrombolysis. Clear? So let me summarize again. If I have a patient less than 4.5 hours from the onset of stroke he has presented, we go for thrombolysis. 4.5 to 9, only if penumbra is present on CT or MR perfusion imaging. After 9, we generally don't consider it. But if it is unknown onset or if it is wake up stroke, we can go for thrombolysis. If there is still a penumbra present on CT or MR perfusion imaging, or there is a diffusion weighted imaging and flare mismatch present, then we can go for thrombolysis. If these two are not there, those cases will be treated just like the post 9 hours, post 24-hour cases. Okay, is that clear? Now let's also learn making a decision about deciding about endovascular thrombectomy. Deciding about endovascular thrombectomy. So if it is an ischemic stroke, if they have presented within 6 hours, we will certainly go ahead within 6 hours, and CT angio shows large vessel occlusion. I've already told you what is considered as large vessel occlusion. Internal carotid artery, M1 segment of MCA, P1 segment of PCA, basilar artery, vertebral artery, and selected cases of M2 segment MCO occlusions are considered as large vessel occlusion. So if they are presented within 6 hours, clearly you will have a penumbra. So you can go ahead with EVT. Okay, if they are presented within 6 hours, but the CT angio has not shown the presence of large vessel occlusion, there is possibly a small vessel or medium vessel occlusion, no large vessel occlusion, then they become ineligible. Right? They are ineligible for EVT. Ineligible for endovascular thrombectomy. Okay. So that means to decide about EVT, I need to know where is the clot sitting, right? I have to go for CT angio. That's why I told you initially only when you're evaluating a case of stroke to know whether it is ischemic or hemorrhagic, in the same sitting, finish off the CT angio itself, so that you have the clarity. By the time you have to take a decision about EVT, you already have the CT angio imaging in front of you. You already know where is the block sitting, whether it is in the larger vessels, EVT feasible, or it is in smaller vessels where EVT is not feasible, right? Okay. Now, if they have presented after 6 hours up to 24 hours, As I've already told you, after 24 hours, they become ineligible for EVT because there will be no penumbra that I can save. So they are ineligible for EVT. So I'm not definitely doing there. But 6 to 24 hours, I need to prove that there is a penumbra which can be saved. If there is no penumbra, then there's no point in doing EVT, right? So that's why after 6 to 24 hours, we have to go for CT perfusion imaging, CT or MR perfusion imaging to prove the presence of penumbra. If penumbra is present and on the angio, there was a large vessel occlusion. So if there is no penumbra, by default, they are ineligible for EVT, right? But if there is a penumbra present and the CT angio shows large vessel occlusion, then you go for EVT. Even when penumbra is present between 6 to 24 hours, but CT angio shows the occlusion is not there in the large vessel, then again, anyway, I can't do EVT, right? They become again ineligible for EVT. Ineligible for EVT, right? Clear? This is what we know about the management of stroke. So I have to have an algorithm for deciding about EVT and deciding about the IVT. And if they fit both, we do both. If they fit only one, we do only one. So let's take a case scenario and apply our knowledge and to see if we can make the right decision. Okay. So we will have one patient here now. So I have a 50-year-old male, 50-year-old male. He is diabetic. His HbA1c was 8. He is also hypertensive and BP on presentation or at presentation is 190 by 120. Okay. His last known well was 7 hours ago. 7 hours ago. So we will presume the onset of stroke 7 hours ago. Okay. Then when the non-contrast CT was done, because now he has present, okay, let me say his clinical features of presentation. So he has presented with right hemiplegia. Okay. And also right facial weakness and Broca's aphasia. These are his clinical features. Okay. So because all of these symptoms have rapidly evolved, 7 hours ago he was perfectly normal. So I'm certainly thinking about stroke. So when he came to the emergency room, we got a non-contrast CT done which showed no bleed. That means hemorrhagic stroke is ruled out. And in the same sitting, because my hospital had the facility to get a CT angio done, I've got the CT angio done and it shows occlusion of M1 segment of MCA. Okay. So this is the story so far. So now tell me, what is the next thing that you want to know for this patient? What I can do for this patient now? Now for thrombolysis, the window period is extended to 9 hours. EVT window period is extended to 24 hours. That's what I told you, right? In the algorithm, up to 9 hours you can take for thrombolysis. EVT can be done up to 24 hours. Okay. So now what is the next thing? So onset is more than 7 hours ago, right? I have to now decide whether he is eligible for EVT, whether he is eligible for IVT, and then decide what to do, right? Yes, because it is, first let us decide about, in this case, the first let us decide about the IV thrombolysis, then we will talk about the EVT. Okay. So for IV thrombolysis, the patient, like we can go for IV thrombolysis up to 9 hours. If it was within 4.5 hours, we clearly know there will be a penumbra, so I don't need to do anything. I can proceed with thrombolysis if there are no contraindication. But 4.5 to 9 hours, I need to know whether there is a penumbra that I can save, because I don't want to take unnecessary risk. So in that case, to decide about IV thrombolysis, I need to go ahead with CT or MR perfusion imaging, right? I would prefer to go ahead with CT for quicker result. So I might have to think of doing a CT perfusion imaging. That's a good move. Okay. Now, let us also decide about EVT. What should I do now? From the point of view of EVT, also he is outside the standard window period. If it is within 6 hours, we generally go ahead with EVT. If it is an acute ischemic stroke, which is major or minor with disabling symptoms, we go ahead with EVT. Now here he has all these symptoms, so this will by default be a major stroke. So for EVT point of view, he is outside the standard window period. So what should I do in that case? So he falls in this, right? 7 hours after the onset, we have seen him. So he falls in this. So again, for this also, I need to do a CT or MR perfusion imaging, right? So from the point of view of EVT as well as IVT, I need a CT or MR perfusion imaging. So once I do a CT or MR perfusion imaging, the result will decide whether I will do thrombolysis and EVT or not. Okay. Now the CT perfusion imaging, let us say it shows presence of penumbra. Penumbra is present as per the CT perfusion imaging. So in that case, he becomes fit for thrombolysis. He also becomes a candidate for EVT because there is a large vessel occlusion plus penumbra is also there. So he is now eligible for both IV thrombolysis as well as EVT. So now tell me what all steps I need to take. So here we will try to manage with both EVT as well as IVT, but we have to remember one point. The BP for IV thrombolysis should be less than 185 by 110. So I have to also take a decision about the blood pressure. This BP should be lowered to less than 185 by 110. And then you can go ahead with IV thrombolysis. EVT, the BP is not a contraindication at all. So you can directly go ahead with EVT from the BP point of view. But for thrombolysis, you have to lower the BP. For quick lowering, we usually use something that can be administered as IV, right? So I can give IV labetalol, bring the BP to less than 185 by 110, and then start giving the thrombolytic agents. And as soon as the EVT team is ready, either during the thrombolysis or soon after completing the thrombolysis, we can go ahead with EVT. We need not delay the EVT to see the result of thrombolysis. That's what we used to do in the past. Today, give the thrombolytic agent, take the patient for EVT. Or when you're doing the thrombolysis, when the thrombolytic agents are being administered, you can take the patient for EVT. EVT should not be delayed for completion or seeing the result of thrombolysis. That's an important new update. Yes, that's what. So the BP is a relative contraindication here, but you can give IV BP lowering medications like labetalol. Quickly lower it. If you're able to lower it, then you can go ahead with IVT. If you're not able to lower it, then it becomes a contraindication. Then he is no longer eligible for IVT. He remains only eligible for EVT. Okay, so that's the approach. So whenever we have a patient with stroke, we have to decide what should we do for his BP. Should I treat or not? We have to decide what is going to be the reperfusion strategy. Clear? IVT plus EVT or IVT alone or EVT alone, that should be decided. Now, in this case, yes, we do agree that this patient is technically eligible for IV thrombolysis as well as EVT, provided the BP gets sorted. If the BP is sorted, IVT plus EVT. BP not sorted, then only EVT. Okay, but now let us change this scenario and let's say the same patient, but instead of 7 hours. He has presented 3 hours after the onset of symptom. Rest of the thing is same. Tell me what's the step that you are going to take. So if I have to think about IV thrombolysis eligibility, yes, BP is a red flag here, but yeah, I can give labetalol and lower it. So I'm not too much worried about it. I will certainly have to do that. Without doing that, I should not go for thrombolysis. Yeah, but he is now within 4.5 hours. Clearly the standard window. I don't need to do any further imaging. So I don't have to do a CT perfusion imaging to prove that there is a penumbra. I can directly go for thrombolysis because I'm reasonably certain that there will be a penumbra present, right? So he becomes a case eligible for IV thrombolysis provided the BP is taken care of. But what about EVT? He's well within the 6-hour standard window period for EVT, and occlusion is in a large blood vessel. So he becomes eligible for EVT as well. So in this case, I don't waste time doing CT perfusion imaging. I will take care of the BP, go ahead with thrombolysis, and then push the patient for EVT. Okay, let us change the scenario again. The same story, but the occlusion is there in the, instead of M1 segment of MCA, occlusion is there in the M3 segment of MCA. 3 hours, but M3 segment occlusion and rest of the things are same. So from the point of view of IVT, he is still eligible within 4.5 hours window period. So I can definitely go ahead with IV thrombolysis. But he is no longer eligible for EVT because EVT is only feasible when you have a large vessel occlusion. Now M3 is not a large vessel occlusion. So he is not eligible for endovascular thrombectomy. So this is how our management changes. So every case you have to assess whether they are eligible for IVT and EVT. Okay, is that clear? Now, few more points. If I'm going for thrombolysis, what agent I should use here? Because in this case, he was eligible for thrombolysis and EVT if I control the BP. So I will give a labetalol and then go ahead with thrombolysis. So when we are doing thrombolysis, the point to remember is we have many choices. But then there are only 2 drugs which are FDA approved for thrombolysis. And in terms of recommendation, not one of them is preferred over the other. Both are considered equal. For many years, we used to use Antiplatelets as the only approved drug for thrombolysis. Now it is considered equivalent to newer drug, that is Tenecteplase. These are the 2 drugs approved by FDA. These are the 2 drugs which are listed in the ASA stroke guidelines. So if I'm using Altiplase, now if you have watched my previous stroke lectures on the YouTube or the app, you might have seen me pushing more towards Tenecteplase over Altiplase. There are reasons. Altiplase, the administration is cumbersome. So if I'm giving a Altiplase as a thrombolytic agent, first I have to calculate the total dose. The total dose is going to be 0.9 mg per kg. 0.9 mg per kg, and the max dose should not exceed. The dose should not exceed 100 milligrams, even if the weight says otherwise. Even if the weight says otherwise. And whatever is the total dose, like, shall we apply to our own case and see how much should we be giving? Here we have a 50 kg person, right? I have not mentioned the weight. Let us say he is a 50-year-old and 50 kg. So if he is 50 kg, how much should be the total Altiplase dose for him? 0.9 into 50. That becomes 45 milligrams, right? 45 milligrams. Yeah, I'm addressing the drugs itself. So in that case, if I'm talking about a 50 kg person, then I will be giving 45 milligrams, right? So total dose becomes 45 milligrams. So if I have a 50 kg patient, then total dose becomes 45 milligrams. But if I had a 150 kg person, then the total dose will be 45 into 3, almost like 135 milligrams. But will not go to 135. If the weight says otherwise, we will still stick to maximum of 100. Within 100 weight base, after 100, if the weight based dose is more than 100, we will still give 100 only. So in this case, 50 kg individual, the total dose becomes 45. Out of that, 10% is administered as 10% of total dose is given as IV bolus, and remaining 90% of total dose is given as infusion over 1 hour, IV infusion over 1 hour. Bit cumbersome, right? Like I have to first calculate the total dose. Out of that, like here, if the total dose is 45 milligram, then the bolus dose becomes 10% of it, that is around 4.5 milligrams. And remaining 40.5 milligrams becomes infusion dose, right? Remaining 40.5 milligrams becomes infusion dose. So you will just push 4.5 milligrams and then remaining 40.5, or you can generalize saying 5 milligrams I will push as the bolus, and remaining 40 milligrams I have to run as an infusion over next 1 hour. Quite cumbersome. The advantage of tenecteplase lies here. The total dose that we calculate for tenecteplase can be administered as bolus. You don't have to run the infusion. So that makes it much more easier, right? So total dose here is going to be 0.25 milligram per kg, and the max we can use is 25 milligrams. Max we can use is 25 milligram. And then please note the total dose is administered as bolus. There is no infusion involved here. So thrombolysis, thrombolytic agent administration is just one push, nothing cumbersome, right? That's why clinicians prefer this over alteplase. It's like this case scenario we had. Patient was eligible for IV thrombolysis as well as EVT, right? BP was high. I will give labetalol, maybe 2-3 doses of labetalol. Quickly, within minutes, the BP will come down to less than 185 by 110. And then whatever is the calculated tenecteplase dose, our patient was 50 kg in weight, right? So if I had 50 kg, 50 into 0.25 becomes 12.5. Yeah. So total dose becomes 12.5 milligram, and all this 12.5 milligram will be given as IV bolus. There is no need for infusion. So I would control the BP in our case, give 12.5 milligrams of tenecteplase, one push, done. Thrombolytic agent is delivered to the patient. And after that, I will involve the EVT team. EVT is usually done by interventional radiologists or neurologists who are trained in it. So I will hand over the patient to them, do the EVT. Thrombolysis part is already taken care. I did not waste much time, right? I did not have to delay EVT because my thrombolysis is taking time and all. No, that mess is not there. That's why tenecteplase becomes a good drug here. The guidelines do not prefer one over the other. They say both are equivalent, but clinically we find this more convenient. Okay, understood. So now we have literally got the picture of how we are managing the case of stroke. So this patient, the scenario that we had created, he had presented after the standard window for EVT as well as IVT. So I had to go ahead with CT perfusion imaging. If CT perfusion imaging showed a penumbra, then he becomes eligible for IVT as well as EVT. EVT up to 24 hours we can do. IVT we can do up to 9 hours. So he is falling in the extended window period for both. So I should do both. Step number 1, quickly lower the BP. Once I lower the BP to less than 185 by 110, I will administer tenecteplase. This patient is now considered as 50 kg, so 12.5 milligrams of tenecteplase. And after that, hand over the patient to interventional radiologist for a EVT, right? And once the EVT is done, hopefully we would have already dissolved some clot by thrombolytic agent, and the interventional radiologist will retrieve the remaining clot. We will re-establish the blood flow. Penumbra is salvaged. Once the penumbra is salvaged, whatever functions we had lost because of the penumbra, we will recover it. So maybe let us say here, the hemiplegia is due to infarct, but the facial weakness and Broca's aphasia is due to penumbra. So after the IVT and EVT is done, this will recover. The facial weakness will get better. The drooped face will become normalized. Broca's aphasia will get sorted. Only thing that will remain is right hemiplegia. If you had presented even earlier, maybe 1 hour, then maybe this also penumbra, and my IVT and EVT would have done wonders. This patient would have come on a stretcher with hemiplegia, facial weakness and Broca's aphasia, but when he goes home, he can go home walking, I could have recovered everything, right? So time is brain, time matters a lot. Earlier the present, better it is in terms of functional outcome. Okay, is that clear? You have a fair idea how we manage a case of stroke. Little more things to address. One is BP and use of antiplatelets. BP and antiplatelets. Yes, if you're using tenecteplase, the thrombolytic agent is given as a single bolus dose. Whatever is the calculated dose, you just push it. If you're going for the altiplase, you have to give 10% of the calculated total dose as the bolus and remaining 90% as an infusion running over next 1 hour. So now pending thing is deciding about BP and deciding about antiplatelets, because I did tell you that increase in the BP is one of the counter mechanism which is trying to deliver more blood through the narrowed blood vessel to brain. So it is a kind of a protective physiological adaptation. So if I lower unnecessarily, the penumbra gets converted to, because blood flow drops in the penumbra, it gets converted to infarct much faster, right? So that's why what influences the BP decision is whether we are going for revascularization or not. So if you are having a case of stroke, if it is to be managed by revascularization, then our BP management is different. And if you are not going for EVT or IVT, then our BP management is going to be different. If you're not going for EVT or IVT, then you should treat BP only if it is more than 220 by 120, because up to 220 by 120 your blood vessels can tolerate and it is helping you keep the penumbra alive. So this is a protective physiological adaptation and I don't want to lose that. But more than 220 120 the risk of bleeding increases, so I don't have a choice. Even though I know it is helping to keep the penumbra alive, it's not safe because I can bleed in the brain, so that's why we treat it. But if the patient is to be managed by revascularization, if I'm going for IV thrombolysis, the tolerance level drops to 185 by 110. What I could tolerate as a normal blood vessel, 220, 120, I can't tolerate. I can bleed before that, right? So if you're going for IV thrombolysis, pre-thrombolysis, your BP should be lowered to less than 185 by 110, right? Lower it to less than 185 by 110. If it is less than 185 110, already good, but if it is more than that, you have to lower it. If I'm not going for EVT IVT, I will lower it only if it is more than 220 by 120. But for IVT patients, we'll lower it if it is more than 185 by 110. But after thrombolysis, for first 24 hours, right? For first 24 hours, we need to still maintain lower blood pressure. For first 24 hours, your target is to keep it below 180 by 105. So before thrombolysis, it should be less than 185 by 110. And once you administer thrombolytic agent for next 24 hours to ensure that major bleeding doesn't occur, you have to keep it below 180 by 105, which like subtract 5 from systolic and diastolic. That's your goal. If you're going for EVT, blood pressure is not a contraindication to go for EVT. So you can certainly go ahead, even if it is 210, 200, doesn't matter. You can go ahead with EVT. But post procedure, post EVT, we need to maintain low pressure. So what is the target? Same as post IVT target, that is 180 by 105. So you have to maintain it less than 180 by 105. This is about our BP management. So now in the scenario that we had here, our patient's BP was 190 by 120. So before IVT, I have to lower it to 185 by 110. Once it is lower than that, I can do the IV thrombolysis. But once I do thrombolysis, for next 24 hours, I should ensure that the BP remains less than 180 by 105. What 2026 guidelines also recommend is don't lower below 140. Lowering below 140 is not necessary, may bring unnecessary harm. So keep it above 140 up to 180 systolic. Diastolic should be kept less than 105, right? So here I can say the clear target for BP is going to be 185 by 110, but you should make in both the cases not to decrease systolic BP less than 140 millimeters of mercury. Means your safe systolic range for first 24 hours is going to be 140 to 180, diastolic anything less than 105. Okay. Now another thing is deciding antiplatelets, because mainstay of treatment is going to be IVT and EVT. Deciding antiplatelets. So if you have a case of stroke in the emergency room, right, you have to first decide whether you are going for IVT EVT or no IVT EVT. So if you are going for IVT and or EVT versus no IVT EVT. If your patient is not eligible for IVT and EVT, like let us say patient is presented after 9 hours, he is clearly not eligible for IV thrombolysis. Up to 24 hours, he still may be eligible for EVT. But I got a CT perfusion imaging, there is no penumbra. Then he is not eligible for EVT either. Or I've got a CT perfusion imaging, there is a penumbra, but the occlusion is in a small blood vessel. So then he is still ineligible for EVT. So such patients where neither IVT nor EVT is being done, in those patients, you can certainly go ahead with single antiplatelet therapy. You start with aspirin and you continue it for life. Continue it for life. Remember, dual antiplatelet therapy is only considered for patients who had minor stroke with no disabling symptoms, or we had considered it for TIA patients. Remember, here I am talking about major stroke or minor with disabling symptoms. With disabling symptoms. Minor without disabling symptoms, we don't even think about IVT, EVT, we just start them with dual antiplatelets. Okay. If I'm going ahead with IVT, EVT for these patients, in that case, no antiplatelets for first 24 hours. Don't give antiplatelets in the first 24 hours of the presentation, because you're going to do revascularization. Having thrombolytic agents and antiplatelets both administered together increase the risk of bleeding. So I don't want to take that risk. So what you do is, don't give first 24 hours. You do a CT 24 hours after. CT 24 hours after IV thrombolysis. And if no bleed, because IV thrombolysis might have resulted in bleed, only if there is no bleed, then you start them on single antiplatelet therapy for lifelong. So if I have to give aspirin to a patient who is supposed to be taken up for intervention, IVT or EVT, you should be giving it 24 hours after the presentation. Like during this period, patient undergoes the intervention, and post intervention you do a CT scan 24 hours later to ensure that bleeding has not occurred because of as a side effect of your thrombolysis, and only then you start aspirin. If you see bleeding, don't give aspirin. Clear? Common mistake, this happens among a lot of interns in the emergency room. Once the patient comes with some focal deficits, they think of this as stroke. CT done, no bleed, so they know it is not hemorrhagic. So they immediately administer antiplatelet agents. But if after administering antiplatelet agent, if the patient is eligible for IVT and I take him for IVT, I might end up with some major catastrophic bleed. That's why it's very, very important that you take decisions about IVT, EVT, BP management and use of antiplatelets in a fragmented way. Everything you have to analyze as per the protocol, right? So I hope you have the clarity on the management of stroke today. I'll see you in the next lecture. We will discuss another such important topic. If you want, I will share some clinical scenarios and you can think in your mind how you are going to approach those scenarios from the stroke perspective. Should I go for IVT here or not? Should I go for EVT here or not? Should I give antiplatelets in the initial presentation or after 24 hours? Should I lower the BP or not? By approaching the case through the algorithms that we have learned today. That's it from me today. I'll see you in the next class. Till then, have a good time.